It's live.
Okay, hello. Hello everyone. We are broadcasting here from Zagreb, Croatia for Neurosurgical TV. Today we have the pleasure of having Dr. Rakesh AV and myself having first Rhoton reading session. So the initial idea was to read some chapters of Professor Rhoton's great and famous book Rhoton cranial anatomy and surgical approaches, and to discuss some of this anatomy in order to try to achieve some better understanding and learning. So Rakesh, please feel free to participate because this is our hangout, okay?
Yeah. Hi
Hello.
everyone. Hello.
Okay,
Hi
so
everyone. This is Dr. Rakesh AV from India. I'm a neurosurgical resident, and I and Slaven are the team members of Neurosurgical TV,
mhm.
making neurosurgery education worldwide easily accessible. So today we are going to discuss a Rhoton and neuroanatomy. Okay, go ahead,
Yes,
Slaven.
yeah. So yeah, let's set it on. So today we agreed to go through the first uh, chapter of the supratentorial part of the book, and this chapter is called the Cerebrum, one of the major chapters of the book. So Rakesh, can you see this?
Yeah, I can see this. Cerebrum.
Okay, great. Yeah,
Yeah.
the Cerebrum. So I just wanted to make a brief introduction. You all know this great book. This is exactly the another supplement that went out in the journal Neurosurgery. You can see the year here. So it's November 2002. And this is one of the classic supplements that are used as literature in neurosurgery today. I think in all residency programs, and really there is not a neurosurgeon who is not introduced with this work. So I will just start reading, and we can discuss as we go through the way. And later on, we'll try to discuss some questions from this session also. So we hope this will be helpful to our viewers at this time. Okay, Rakesh, so if you agree, let's set it on.
We- Yeah, let's
Okay.
start.
Okay, so I'll just start reading it. So the author of this text is Professor Rhoton. Okay, so the cerebrum. The cerebrum is a remarkably beautiful and delicate structure. The goal of the study of microsurgical anatomy is to perform gentle, precise, and accurate neurosurgery and to be able to navigate safely around and through the cerebrum and intracranial space. Essential to proceeding through the cranium and the brain surface to the depths is an awareness of the site of the most valuable and vulnerable cortical and subcortical areas and the location of these eloquent areas in relation to the cranial and cerebral landmarks. This requires that the surgeon have a see-through X-ray type microsurgical knowledge that visualizes deep structures in relations to the surface area exposed and weights the value of tissue along each route to the targeted intracranial and intercerebral sites. The tentorium cerebelli, a dural projection, divides the intracranial space into supra and infratentorial compartments. The posterior cranial fossa is located below the tentorium in the infratentorial compartment, was the subject of the Millennium issue of Neurosurgery. So that was the prior edition, a supplement to Neurosurgery journal in 2000, and it was termed Millennium issue because of the year 2000 and because of its significance, because this was the first altogether published work of Professor Rhoton on the posterior cranial fossa that was never published before as a set. So it was indeed a big achievement for the Neurosurgical Society. The supratentorial area and the anterior and middle cranial base are the focus of this issue. In developing this concept of see-through X-ray type knowledge of the supratentorial area, the location of selected deep structures are described in relation to the cranial and superficial cerebral landmarks. In numerous stepwise dissections, the author has tried not only to peel away and describe each layer, but also to clarify the relationships between structures in different layers. One example is the relationship of the ventricles to the cerebral convexity. The frontal horn is located deep to the inferior frontal gyrus. The atrium is deep to the supramarginal gyrus, and the temporal horn is deep to the medial temporal gyrus. We will show this in a second. We will just go through this text now and then view the images. Another example is the relationship of the foramen of Monro to more superficial structures. In the cranial surface, the foramen of Monro is located deep to a point approximately 2 cm above the pterion, just behind the lower third of the coronal suture. At the cerebral surface, it is located deep to the central part of the pars opercularis of the inferior frontal gyrus, and at the insular level, it is located deep to the central part of the second short insular gyrus. Many other relationships between superficial and deep structures are examined. In describing these relationships, the use of the terms superior, inferior, anterior, and posterior is the same as commonly applied in naming the cerebral gyri and sulci. The directional terms are used as follows: superior or above, situated toward the cranial vertex; inferior or below, situated toward the cranial base; anterior to or in front of, situated toward the frontal pole; and posterior or behind, situated toward the occipital pole. Okay, Rakesh. Hello.
Slavan? Yeah, hello, Slavan.
Hello, okay. So I just wanted to ask you, after this short introduction, are there any details that you would like to discuss at this
I
point?
think Yeah, I think we should just go into the diagram, that is figure 1.2, which they have
Yes, yes,
stated in that, and just we'll
exactly.
discuss.
Okay,
Yeah.
okay. So I just wanted to show this image very
Mm,
shortly. So this is the
mm,
first image where we can see the gross total view of the cerebrum. My idea was to, because I have a tablet here with the same text, so my idea was to show you the pictures while I read the text. But if you want, we can first discuss the figure 1.2.
yeah.
So yes, this is exactly the gross total view, and this is the stepwise dissection. So we'll start from here. Okay.
Okay.
Okay, so I'll start reading it, and I will try to read while you can view the images.
Yeah,
Please
yeah, I
tell
can
me
see.
if you want to enlarge anything, or so
Yeah,
feel free to
I.
comment.
F- yeah, 1 minute. I just feel that the A diagram. Can you can you zoom it? I think there is a plus
Yes,
button there. Yeah, yeah,
yes, 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 yes. So
yeah, yeah.
like
This one
this,
is
or
one minus, one minus.
yeah, I can also do
Yeah.
this. Just a second
Yeah.
to yeah, just one minus. I agree.
Mm,
Okay, like
okay.
this.
Yeah.
I think this is the best. Okay.
Mm,
So let's first read what we have here. So we can see the precentral gyrus, this one.
mm,
Yes, we
okay.
can see how it nicely joins here with the just above the sylvian fissure. In I think in 70 or 80% of cases, these two, the posterior central gyrus and the precentral gyrus are connected. They form a loop. So
Yeah.
this was one of the questions I think on sometimes appears on the boards.
Mm,
I found this in Greenberg's Handbook of Neurosurgery. When you have those questions additional to the book. So
yeah.
in very rare, in much more less amount of people, is not conjoined here. We have the supramarginal gyrus, which is part of the parietal lobe, then the ungulate gyrus, inferior frontal sulcus, pars opercularis. This is here. So opercula, which means that it covers the sylvian fissure, and
Mm,
pars orbitalis. This is all the frontal lobe here, and also the
mm,
sylvian fissure, as I noted. Okay, I'll just go through the text now.
yeah.
Rakesh, please comment at any point if you really. This is our hangout, as I said.
Yeah, sure. Yeah, yeah.
Okay, so figure 1.2, which we are viewing, stepwise dissection of the left cerebral hemisphere. So this is for the whole figure, and now it goes into parts like A, B, C, and so on. So
Mm,
first part is number A. The inferior frontal gyrus is composed of the pars orbitalis. So this is here. Pars opercularis here, and the pars triangularis. So here. So we have the pars orbitalis, pars triangularis, and pars opercularis. Okay.
okay.
So these three parts form the inferior frontal gyrus. So we have the superior frontal gyrus and inferior frontal gyrus.
Mm,
Okay.
mm,
So the cilium fissure extends. Legend continues the next page. Okay. So the
okay.
cilium fissure extends backward
Mm,
and turns up
okay.
into the supramarginal gyrus at its posterior end. Okay.
Yes. Yeah.
The lower part of the postcentral gyrus is positioned in front of the anterior bank of the supramarginal gyrus.
Okay.
So the postcentral gyrus is positioned in front of the anterior bank of the supramarginal gyrus. So this is the supramarginal, its anterior bank is this, and this is the postcentral gyrus. So the
Mm,
posterior bank of the supramarginal gyrus is continuous with the superior temporal gyrus.
mm,
Okay, so posterior bank of the supramarginal gyrus
mm,
is continuous with the superior temporal gyrus.
yes.
This means that this gyrus here just continues, if I'm
Yes.
correct, with the supramarginal. Okay, so I'm correct. Okay, so uh, then it says the central sulcus ascends between the pre and post central gyri. Okay,
Yeah.
central sulcus is right here.
Mm.
Okay, then
I want to comment something.
yes,
Right?
of course,
The central sulcus joins the sylvian fissure in only 2% of the cases.
only 2%.
Uh,
Great, great. Thank you
yeah,
for finding.
yeah.
Mhm.
This is I am quoting from Greenberg.
Okay,
Uh,
great, great, great.
Greenberg is in front of me, and I'm quoting from Greenberg. The central sulcus joins the sylvian fissure in only 2%, and hence there would be a subcentral sulcus
Mhm.
present in 98% of the patients. Subcentral
Okay.
gyrus, I mean. Yeah.
So 98 2%. This is amazing.
Yes, this is amazing. Yeah.
Yes, thank you. Thank you
Yeah.
for
Yeah.
correcting and for the
Yeah.
information, Rakesh.
Yeah. Yeah. Yeah.
This is great. Okay,
Mm,
so as I said, okay, I will just continue with this. Let me just orient. As I said, um, we have the central sulcus, which ascends between the pre and post central gyri here.
yeah. Yeah.
Then there is commonly a gyral bridge, red arrow.
Mm,
This, yeah, as we said, connecting the pre and post central gyri below the lower end of the central sulcus, so that the central sulcus does not open directly into the sylvian fissure. Often with the limited craniotomy opening, the whole sylvian fissure is not exposed to aid in identification of the pre and post central gyri and the central sulcus. The position of the lower end of the pre and post central gyri can be approximated by identifying the pars opercularis just in front of the precentral gyrus and the anterior bank of the supramarginal gyrus just in back of the postcentral sulcus. The angular gyrus wraps around the upturned posterior end of the superior temporal sulcus. Okay, I would just like to stop here and go through this a little bit more precisely. So, as I read, the position of the lower end. In a craniotomy, we cannot usually visualize the whole cilium fissure because it's exactly the whole hemisphere. If we look, we would need to expose the whole hemisphere in order to view it. So it says here that in order uh, to visualize, to orient ourselves according to the Sylvian fissure, we can see that the position of the lower end of the pre and post central gyri can be approximated by identifying the pars opercularis just in front of the precentral gyrus and the anterior bank of the supramarginal gyrus, just in back of the postcentral sulcus. So this means that the lower end of the pre and postcentral gyri, so these two, this loop here can be approximated by identifying the pars opercularis, so this part, just in front of the precentral gyrus over here, in the central sulcus. Okay, so we can usually see this small part, let's say. We can readily recognize the Sylvian fissure, but then we should find the loop which is usually there, and then see that there is a central sulcus beneath it, in this loop, and then find the pars opercularis just in front of this loop. So we have then the inferior frontal gyrus, the connection between the the precentral gyrus and the postcentral gyrus. So I think this makes sense.
That was very nice. That was very nice description. So basically, we can see the loop there, the loop connecting the precentral and the postcentral gyrus, and the in between the loop, the sulcus which goes is the central sulcus,
Yes,
and the one which is in front of the precentral gyrus is the pars opercularis. Yeah,
yes.
that's very nice. That's
Yes,
very nice.
exactly, exactly. Great, great. I
Yeah,
think what's amazing with this literature is the clarity in which Professor Rhoton describes all these structures.
yes, yes,
Okay, and it says the angular gyrus wraps around the upturned posterior end of the superior temporal sulcus. So he says the angular gyrus is this.
yeah,
So it wraps around the upturned posterior end, this of um, the superior temporal sulcus. So yes, it means that we have a posterior temporal sulcus here, I think, or no, here. So
mm-hmm.
angular gyrus just wraps around it. So this means
Yeah,
that the superior temporal no, posterior temporal sulcus is approximated to the Sylvian fissure,
yeah,
if I'm
yes,
correct. Okay.
mm-hmm.
Okay, so now we'll continue to the number B.
Mm-hmm.
Over here, if everything is clear, I think this is. So we have the Sylvian fissure, inferior frontal gyrus,
Yeah,
the loop in 98% of patients,
yeah,
and the angular gyrus. Okay.
mm-hmm.
So now here in number B, just a moment. Okay.
Yeah,
So it says B, the part of the frontal lobe above the inferior frontal gyrus and in front of the precentral sulcus has been removed while preserving a thin layer of the medial part of the hemisphere. So part of the frontal lobe above the inferior frontal gyrus over here has been removed in front. Just a second.
okay,
No. Just a second. I think I got it wrong. The part of the frontal lobe above the inferior frontal gyrus and in front of the precentral sulcus. So above the inferior frontal gyrus and in front of the precentral sulcus
yeah,
gyrus has been removed while
mm,
preserving a thin layer of the medial part of the hemisphere. So this is also the medial part of the left hemisphere, which we
mm,
are usually. So this is not the right hemisphere. This is
okay,
the medial part of the left hemisphere. The inferior frontal sulcus is located on the convexity at the deep level of the lower margin of the corpus callosum and roof of the frontal horn. So, inferior frontal sulcus uh, is located at the convexity at the deep level of the lower margin of the corpus callosum and roof of the frontal horn. So this is the roof of the frontal horn here.
yeah,
So we have the lateral ventricle. Corpus callosum is here. It is quite bright, so perhaps like this we'll see it better. So
yeah,
this is the roof of the frontal horn. This is the corpus callosum, and it says here that the inferior frontal sulcus is located at the convexity of the
Mm.
deep level of the lower margin of the corpus callosum and roof of the frontal horn. So here at this deep level, there is a sulcus, which is the inferior frontal sulcus. I think this can be visualized here probably. Yeah, this is the inferior
Yes.
frontal sulcus.
Yeah.
Okay, so if we continue going deep into the inferior frontal sulcus, we will eventually come to the roof of the uh,
Mm.
frontal horn of the lateral ventricle
Yeah.
and more deeper to the corpus callosum. Okay, so I think this was stated in this part.
Yes.
And then it continues. The gray matter of cingulate sulcus is exposed above the corpus callosum. Okay, so I'll just go back. So the gray matter of the cingulate sulcus here
Yes. Yeah.
is exposed above the corpus callosum. Then, and this is all that is stated for this. So we just here we just can see the removed frontal lobe and what is deep to the inferior frontal sulcus, and also that cingulate sulcus is deep, so is superior to the corpus callosum. Okay, any comments, Rakesh, at this point? No.
Yeah, and yeah, it was a very nice illustration of comparing A and B slides, and the thing that the inferior frontal sulcus is goes deep to the roof of the and frontal horn of the lateral ventricle. That's a very nice landmark for the surgeries, and
Mm-hmm.
that's very good. Yeah, this is why neuroanatomy is so useful. Reading
Mm-hmm.
in depth
Mm-hmm.
in a book like Rhoton.
Yes,
Yeah,
yes,
yeah,
yes, I agree. Okay,
yeah,
so C, number C, this is, oh, we have a scrambled picture here, I'm
yeah.
afraid. Let me just see what
Okay.
happened. Just a second.
Okay.
Well, perhaps I have this fine in my book here,
I
but
I'll
yes.
try. It is supratentorial, right? Yeah, yeah.
Yes, super.
I'll
Can
try.
you try to screen share? Okay.
Yeah, yeah, yeah. I'll try. I'll try.
Okay, I'll go off the screen share
Yeah, yeah.
for a second. Yeah. Okay.
It's taking time to open.
Yeah, yeah, of course. Just no worries. I think this is really useful because I really feel connected to Rhoton in this way. I mean, to
Yeah,
the knowledge inside the
and
book.
yeah, and Slavan, I think the when you discuss the picture, it was very clear. So I
Oh,
think the what you did while showing the picture and reading that was more effective than while reading the text. The
yes,
showing
yes,
the
I
text
agree.
in the screen. Yeah,
Agree. You know,
yeah.
the way I used to go through Rotten was to first read the pictures in this way and then read the gross text. So maybe
I think that's
we can try to go
yeah,
through the pictures first. Yeah, as you
yeah,
stated, this is
yeah,
the
yeah,
first time, so we are all
yeah, yeah,
like
yeah,
yeah,
yeah.
finding our way.
I got it, man. I'll just share. I got it. It's opening here.
Yeah, okay, okay. You know,
Yeah,
I can continue reading, and then you can just perhaps
sure.
point
Okay.
and
Yeah, yeah,
yeah,
yeah, yeah.
we can go. Okay.
Can you see that?
Great. Yeah, yeah, I see it. Okay. Fine. Great.
Um, I don't know if I can zoom it. There's a problem. Yeah, yeah, I can zoom it.
Mhm.
Can zoom it. Okay. Is it
It's
okay?
just yes, yes, it's okay. It's okay. I just wanted to say that this is the legal version. This is a bot version that we're using, so no worries because of
Okay.
the copyright laws
Hmm.
and everything. So both of us own a Rotten book, and this is just the e book that we're using here. Okay.
Hmm.
So Rakesh, if you're ready, we can continue to the
Yeah, we can continue.
number, yeah, to the number C. Okay.
Yeah, this is number.
Okay, so let me just orient. I'm reading here on my tablet, so don't
Okay,
be confused, guys. Okay, so we have here another moment. Just a moment. I lost my track of the text.
it's
So
okay.
yeah, okay. So in figure C here, we have posterior view of the hemisphere, as it says. The lateral occipital sulcus. No. Just a second. This is not. It's not correct. Yeah, it's somewhat hard. Okay. Finally, I found it. Okay.
Okay,
So as I said, the gray matter of the cingulate sulcus is exposed above the corpus callosum. So we describe this in figure B. Now in figure C, we can see the opercular lips have been retracted to expose the insula, which is defined at its outer margin by the circular or limiting sulcus. Okay, so as it says, the opercular lips, so the lips that were closing, were have been retracted to expose the insula, which is defined at its outer margin by the circular or limiting sulcus. Okay, so we have the circular or limiting sulcus and the insula here in the D, because so as you saw those opercula that we had before, we just retracted them like this, and then we can see insula deep to these opercula. Uh, So the short gyri of the insula are located anteriorly and the long gyri posteriorly. So we have short gyri on the insula anteriorly and the long gyri posteriorly. Okay, and now it goes on to the figure D. We have just seen the insula deep to the opercula, and now in figure D, it says enlarged view with the brain in front of uh, the precentral gyrus removed. Okay, so enlarged view of with the brain in front of the precentral gyrus removed. Okay, the insular gyri radiate upward and backward from the anterior-inferior angle, situated just lateral to the limen insulae. Okay, so the insular gyri radiate upward and backward from the anterior-inferior angle, situated just lateral to the limen insulae. Okay, so we have this gyri of the insula radiate upward and backward. The short gyri are located deep to the pars triangularis and opercularis. So the short gyri of the insula are located deep to the parts triangularis and pars opercularis. Heschel's gyrus, the most anterior of the transverse temporal gyri, faces the lower end of the post-central gyrus across the Sylvian fissure. Okay, so the famous Heschel gyrus of the insula, the most anterior of the transverse temporal gyri, uh, faces the lower end of the post-central gyrus across the Sylvian fissure. Okay, this is all for the figure D. Now we will continue to the figure E. So this is just as Professor Rhoton stated, a stepwise dissection. So every layer here is examined, and every layer is such in-depthly covered, as we can see. Okay, so we're just finding our way through this part of the hemisphere. Okay, so in figure E, anterior superior view of the central core of the hemisphere is located deep to the insula. Okay, so the anterior superior view of the central core of the hemisphere located deep to the insula. The lentiform nucleus is exposed deep to the insula and is separated from the caudate nucleus by the anterior limb of the interior capsule. Okay, so we can see the white matter separating the lentiform nucleus and the caudate nucleus by the anterior limb of the internal capsule. The circular sulcus surrounds the insula. Okay, circular sulcus surrounds here the insula, which is also the gray matter. Okay, then in figure F, the supramarginal gyrus has been removed to show its location superficial to the atrium. So the supramarginal gyrus has been removed to show its location superficial to the atrium. The posterior margins of the insula and circular sulcus are positioned superficial to the anterior edge of the atrium. The posterior margins of the insula and circular sulcus, okay, are positioned superficial to the anterior edge of the atrium. Okay, so we have the atrium of the lateral ventricle, and superficial to it are the posterior margins of the insula and circular sulcus. So deep to the posterior margins of the insula and circular sulcus is the atrium of the lateral ventricle, its anterior edge. Okay, the pre and post-central gyri are located lateral to the body of the ventricle and the splenium of the corpus callosum. Yes, the pre and post-central gyri are located lateral to the body of the ventricle and the splenium of the corpus callosum. The foramen of Monro is located deep to a point on the pars opercularis, approximately 1 centimeter above the sylvian fissure, and deep to the mid-level of the short gyri of the insula. Okay, so it says the foramen of Monro is deep to a point on the pars opercularis, approximately 1 centimeter above the sylvian fissure, and deep to the mid-level of the short gyri of the insula. So it's amazing if you see it in this way. We have the foramen of Monro deep to these superficial landmarks. So as Professor Rhoton says, the see-through X-ray vision of the parts of the hemisphere depends on this. We can remember that we have the foramen of Monro deep to these superficial structures. Okay, so but as I found it, going through this text will put it all in place. So we shouldn't have a trouble with having the general concept of this when we finish reading. Okay, so this is all for the figure F. We can now continue to the figure G. Rakesh, if I'm going too fast or you have
It's
something to add,
perfect.
please.
It's
Okay,
perfect. It's perfect. You are
great.
repeating that. That's great. That's great.
Yes,
Yeah.
yes, I'm trying to make it as simple because I always perceived Professor Rhoton's book as a delight to read. It was
Yes. Yes.
never how can I say? You just have to give it time and be
Mm.
really, really gentle as Professor Rhoton was. So,
Yeah. That's great.
so I think it's really amazing to study it like this.
Yes.
Okay,
Yes. Yeah.
so in figure G, we
Yeah.
can see the color pins have been placed along a line that corresponds to the lower margin of the insula. So this is the lower margin of the insula, which is located deep to the superior temporal sulcus. Okay, so color pins here have been placed along a line that corresponds to the lower margin of the insula. So this is the lower margin of the insula, uh, which is located deep to the superior temporal sulcus. So deep to the superior temporal sulcus is lower margin of the insula, depicted here by these black pins. Okay, a blue arrow has been placed on the foramen of Monro. Okay, so here is the foramen of Monro, and now I will go through in the text the position of this foramen of Monro as stated in front of the other structures. So it says the blue arrow has been placed on the foramen of Monro, which is located deep to the central part of the insula. So it is located deep to the central part of the insula, the foramen of Monro. So deep to the central part of the insula, we have the foramen of Monro. This is amazing. The white arrow is located at the site where the upper end of the ascending ramus of the cingulate sulcus reaches the superior hemispheric border. So it says the white arrow is located at the site where the upper end of the ascending ramus of the cingulate sulcus. So we have the upper end of the ascending ramus of the cingulate sulcus, the superior hemispheric border. So we can see the cingulate sulcus coming right there on the superior hemispheric border where the white arrow indicates. The ascending ramus of this cingulate sulcus courses on the medial surface along the posterior margin of the paracentral lobule. Okay, so we will be able to see this when we will examine the medial aspect of the hemisphere. So it is not visual here, but it is just described that this ascending ramus of the cingulate sulcus continues on the medial aspect of the hemisphere. On the medial aspect of the uh, hemisphere, so along the posterior margin of the paracentral lobule. We will see this on some of the next slides. Okay, now we have H, figure H. The anterior limb of the internal capsule is located between the lentiform nucleus formed by the putamen and globus pallidus and the caudate nucleus. Okay, so we have the anterior limb of the internal capsule, which is white matter, located between the lentiform nucleus. The lentiform nucleus is formed by the putamen and globus pallidus. And we have on the posterior margin of this internal capsule, okay, which separates the two gray nuclei. So on its posterior margin, we have the caudate nucleus. So the anterior limb of the internal capsule is located between the lentiform nucleus and the caudate nucleus. And what forms the lentiform nucleus is the putamen and globus pallidus. Okay? The posterior limb of the internal capsule is located between the thalamus and the lentiform nucleus. So between the thalamus and the lentiform nucleus, we can clearly see here the posterior limb of the white matter of the internal capsule. Now the genu, so the knee of the internal capsule is located just lateral to the foramen of Monro. This can be clearly seen here. So the genu or the flexure of the internal capsule white matter is located just corresponding to the foramen of Monro. Okay, the choroidal fissure along which the choroid plexus is attached is situated between the fornix and the thalamus. So the choroidal fissure along which the choroidal plexus is attached is situated between the fornix and the thalamus. Okay, so we can clearly see the gray matter of thalamus and the fornix. Okay, now when we discussed this, we have the figure I. So in the figure I, it continues like this. The temporal horn and the hippocampus are located medial to the middle temporal gyrus. So the temporal horn and hippocampus are located medial to the middle temporal gyrus, a segment of which has been removed. Okay, so this is amazing. This is simply amazing. I remember that this white, I call it white, but it's you can see this structure in the deep. So you have exactly the hippocampus in depth of the middle temporal gyrus. I think this is amazing. This concept. So you always know that you have the hippocampus deep to the middle temporal gyrus. And then it continues. So the hippocampus sits in the floor of the temporal horn. So in floor of the temporal horn is a part of the lateral ventricle. So floor of the temporal horn of the lateral ventricle is formed by the hippocampus. Okay. And then it says the atrium is deep to the supramarginal gyrus. the atrium of the lateral ventricle is deep to the supramarginal gyrus. So exactly as we see here, where the supramarginal gyrus was a minute before, now is the atrium. Deep to it is the atrium. Rakesh, do you want to show the correspondence? I think it's
Okay,
clear. It's clear.
it's clear. Okay.
Yeah, yeah. So this is really amazing. So we have atrium deep to the supramarginal gyrus, and
I
we
think this is the
have the
supramarginal.
exactly, yeah, exactly. So this
Mm.
is really amazing. So and we also have the hippocampus deep to the
Oh,
middle temporal gyrus. Okay, so we're just we are starting to get the hang of this, guys.
okay.
Okay, so
Okay.
yeah, it takes some time, but when it comes, it's really amazing. You wouldn't change it
Yeah.
for anything, I think. So
Yeah.
so
Yeah.
okay,
I mean,
it's really I'm having a great time. So
yeah. Yeah.
let me continue. I
Mm.
just need to find my way around. So uh, uh, just a second. We have been on the yeah. Okay. Okay, so it says the hippocampus sits in the floor of the temporal horn. The atrium is deep to the supramarginal gyrus. Now the black arrow. The black arrow uh, is on the foramen of Monro. So the black arrow indicates where the foramen of Monro is positioned. The white arrow is located where the upper end of the ascending ramus of the cingulate sulcus reaches the superior hemispheric border. So as we would before, this is the upper ramus uh, of the ascending part of the supramarginal sulcus. Just a second. Yes, so the white arrow is located where the upper end of the ascending ramus of the cingulate sulcus reaches the superior hemispheric border. The yellow arrow is where the upper end of the parieto-occipital sulcus reaches the superior border. So where the upper end of the parieto-occipital sulcus reaches the superior border is where the yellow arrow is. So where the upper end of the parieto-occipital sulcus reaches the superior border. Okay. And uh, just a second, my earphones are about to fall off. Okay.
That's okay. You're
So
doing an excellent job.
yeah, thank you, Rakesh.
Thank you.
Someone had to do this, for the people,
Yes. 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 Yes.
so people
That's
could
excellent.
start enjoying
Yeah.
Professor Rhoton's work and stop being afraid of it, because I know it looks intimidating, but you need to study this together. I think together
Yeah.
everything is more easy, and anatomy
Yeah.
is like the best thing to study together. I think
Yeah.
the
You're
most
right. You're
amazing
right.
subject. Yeah,
Yeah.
that's the way I managed to pass anatomy to like pass that exam. And
Yeah.
yeah,
Yeah. Yeah.
because when you can't read anymore, then you start
Yeah.
talking to people, and it
Yes.
sits, and
Yeah. And when you talk to people, it is registered for a long time. It's registered for a long time. In
yes.
fact, sometimes you remember forever.
Yes, exactly,
Yeah.
as you're
Yeah.
saying, because you can't really forget now that the hippocampus is deep to the
Deep.
middle temporal gyrus, and
Yeah.
that it forms
That's
the
it.
floor, the
Floor. So
floor.
many times you repeated. It's like registered in my mind.
Great. I'm very glad, and this
Yeah.
is exactly what Professor Rhoton wanted to do. He wanted to make surgery more safe for everyone, and
Yeah.
this means that to enhance our knowledge.
Yes.
Because of
Yes.
that, if we remember anything of this in one of the operations that we will have the honor to do, if we become
Yeah.
neurosurgeons, it will be amazing.
Yeah.
Yeah, so
We are
but
going
this
to
is
do.
the work, we were putting in the
Yeah.
work,
Yeah.
man.
Yes. 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 We are going. We are going high.
Yeah,
Yeah.
good. Hope so, yeah. Guys, if everyone is viewing this, please feel free to join and really help us in this phase. And you can also be on the panel in the future if everyone is interested, because this is going live. This is broadcasted to YouTube, and you
Yes.
can all follow this. Okay, so I'll just cut the slack now and continue. So we said that the yellow arrow is where the upper end of the right, occipital sulcus reaches the superior border. Okay, and now let's go on. J. On figure J, the remaining bridge of the superior temporal gyrus located superficial. So the remaining bridge of the superior temporal gyrus located superficial to the junction of the atrium and temporal horn has been removed. Okay, so the remaining bridge of the superior temporal gyrus located superficial to the junction of the atrium and temporal horn has been removed. Okay, and now it proceeds on to decay. So this is really a complete stepslide dissection. Like no, we can't see anything like this anywhere, I think. So K, posterior view of the left hemisphere. The splenium is located deep in the interhemispheric fissure. Okay, so we have the splenium of the corpus callosum located deep here, deep in the interhemispheric fissure. So this is the fissure which is usually used for the transcallosal approaches in neurosurgery, thus giving it the name hanging hemisphere, because usually the patient is positioned, with head rotated in that direction. So the hemisphere which needs to be hanging in order to have the approach is positioned more nearer to the floor, and then you have the hanging hemisphere approach. So this is an amazing name that I remembered.
Yeah,
Usually corpus callosotomy can be done in this way. Yes, Rakesh, if you have some comments, please.
yeah. That's amazing. That's amazing. I didn't know this
Mhm.
point. Yeah, that's amazing.
Mm,
Mm.
I actually know it because I did some research on epilepsy surgery for student journal that we have here at
That's
our
great. And
universities.
and
Yeah,
to the
it was
viewers here, and to the viewers here, whoever is viewing this excellent this thing study course we are doing, the person who is reading, Mr. Slavan, he runs a Rhoton course. He's a Rhoton course to the students at his very early medical education in the third year of his medical education. He's carrying out a Rhoton course. So we have a authority on a Rhoton course telling you about the neuroanatomy.
Thank you so
Continue,
much,
Slavan.
Rakesh. Thank you
Yeah,
so
yeah,
much. Well, this
yeah.
course was blessed by Professor Rhoton himself, and he was alive. But unfortunately, I have the luck that I started it while he was alive, and I managed to say Professor Rhoton how much I admire his work and how much has he done, for me for my approach to medicine in general.
That's
because
great.
because of him, I would never feel such sapio such drive to study
Yes,
into anatomy. And because for me, Professor Rhoton revealed anatomy, and now we have some people who are working with neurosurgical TV. You can also follow them there,
yeah,
such as Victor Hugo Perez from Mexico, who is doing the dissections of the spinal cord. And we hope he will
yes.
publish this in journals and in future in a book. So he hopes to contribute to this neuroanatomical dissection and to give the part of the vertebral column, which misses in Professor Rhoton's book, because Professor Rhoton mainly based his work on the supratentorial and infratentorial space, as I'm
Mm.
aware. So,
Yeah, yeah. And Dr. Victor from Mexico is a great neuroanatomist too. So you people have to watch Victor's this thing seminars on
mhm,
neuroanatomy, the spine. Yeah,
mhm.
it will be of a great
Yes,
value.
yes.
Yeah,
And Rakesh here is really a famous Indian young surgeon who is there with full right. I mean, in this position, an excellent man. So I'm really glad that I managed to meet people like Rakesh and to become such close friends with you over neurosurgical TV. So it's a really great platform for people to share their interests. So Rakesh, thank you
Th-
for being here. Thank you, man.
thanks a lot,
Okay,
Slavan.
so
My pleasure to be here. Yeah.
thank you so much, man. Yeah. Okay,
Okay.
so let's continue where we Stood. Okay, so as we said in figure J, the remaining bridge of the superior temporal gyrus, located superficial to the junction of the atrium and temporal horn, has been removed. Okay, now we
I
will
think
go
we
to
were
the
in
K.
K.
Yes,
Yeah,
yes, yes. I just wanted
I
to
just wanted.
remind.
Okay,
Yes, okay. So in
okay.
K, posterior view of the left hemisphere. Okay. The splenium is located, yes, we started. The splenium is located deep in the interhemispheric fissure. Uh, okay, the parieto occipital and calcarine sulcus converge behind the splenium to give the medial surface a Y-shaped configuration. So the parieto occipital and calcarine sulcus converge behind the splenium to give the medial surface a Y-shaped configuration. Okay, the parieto occipital sulcus separates the precuneus and cuneus. Okay, so the parieto occipital sulcus separates the precuneus and cuneus, and the calcarine sulcus separates the cuneus and lingula. Okay, so the parieto occipital sulcus, which we mentioned before, is important because it separates the precuneus and cuneus. And the calcarine sulcus, which is a place where the visual field is located, separates the cuneus and lingula. Okay, so we can perfectly see this on Professor Rhoton's slides here. Okay, then on figure L, the parietal lobe above the level of the calcarine sulcus has been removed. Okay, the upper lip of the calcarine sulcus. This upper lip is formed by the cuneus, has been removed to expose the lingula that forms the lower bank of the calcarine sulcus. So the upper lip of the calcarine sulcus, which is formed by the cuneus, has been removed to expose the lingula that forms the lower bank of the calcarine sulcus. Okay, so the calcar avis. This means the uh, which part, help me, Rakesh, of the calcar avis of the bird. It's
Mhm. Of the
the
yeah,
what was the weak point of that Greek hero Achilles?
Achilles. Okay,
So
okay.
what's that name
I don't remember Slaven. I don't remember.
Ah, yeah, okay, okay. So we have the calcaravis. So it's
Okay,
part of the foot of the bird. Okay, that's what I
okay,
wanted to say.
okay,
Okay, so
okay.
maybe our viewers will remember and type in,
Yeah,
because
yeah,
we're just trying to be spontaneous here.
yeah,
Okay,
yeah, yeah.
okay. So the calcaravis overlies the deep end of the calcarine sulcus. So the calcaravis overlies the deep end of the calcarine sulcus. So this makes sense because it goes over the deep end of the calcarine sulcus, the calcaravis. Okay, so uh, now we have already came to figure N. So we are just continuing through these steps like this section now. So in figure N, the falx has been removed to expose the medial part of the right hemisphere. So we have here the falx, the falx cerebri removed to expose the medial part of the right hemisphere. Okay. The ascending ramus of the cingulate sulcus reaches the superior border of the hemisphere behind the paracentral lobule. So the ascending ramus of the cingulate sulcus reaches the superior border of the hemisphere
Excuse me,
behind
Slaven.
the paracentral lobule. Yeah,
Sorry to
yeah,
disturb.
yeah, say.
Do you have the this thing PDF? I think if you have, then it would be better if you show. If does this open in your this thing?
Yes, 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 yes. Okay, yes, yes, it's opened. I can screen share.
Okay, sure, 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 sure. Then I'll stop
Okay,
it.
just yeah, yeah, yes. You think we should both screen share? Maybe this is the best, if we both
Hmm.
screen share. Do you agree, or
Yeah, yeah. I'll both will screen share. Okay,
yeah? Let's both go to screen share because we are
okay,
not
okay.
so beautiful. I think. Yeah, I'm joking. You know, like this is
Yeah,
much more
I'm
beautiful.
and we invite a beautiful people so that
Yeah, to join us. Yeah, we need
yeah,
some
yeah,
beautiful people.
yeah,
Yeah, and then people who know how to make better jokes than me, you know.
yeah. Better jokes than us, so that we can
Yeah,
show
yeah,
their face and our face will be shown on their face.
yeah, yeah, yeah. Hello, hey Rakesh.
Hello, Slavan.
Hey, are you here?
Yeah, I'm here. I'm here. I think there
I
was a short interruption.
yeah, okay, okay. But you can see. Can you see my screen share? No, no. Okay.
1 minute. 1 minute. No, I can't see your screen share.
Yeah, yeah, yeah. I understand. I got off my screen share. Okay, just a moment. I'll screen share it again. Okay, okay. So interruptions can. Okay, so now you see it. I hope. Yeah, I think
Mm,
it is. Yeah. Okay.
mm.
Okay. So we'll just continue. As we said, we stopped on figure.
Yum.
Uh,
Yum.
yeah, yeah. Okay. So let me just see. I think I just got some confusion here. So I'll just go again through the figure L. Okay. Just not to make confusion here. Okay, so figure L states the parietal lobe above the level of the calcarine sulcus has been removed. Okay, so the parietal lobe above the level of the calcarine sulcus, which we can see here, has been removed. Okay. Uh, the upper lip of the calcarine sulcus formed by the cuneus. So the upper lip of the calcarine sulcus formed by the cuneus and the just a second and has been removed to expose the lingula that forms the lower bank of the calcareous sulcus. Okay, so the upper lip of the calcareous sulcus, which is formed by the cuneus, has been removed to expose the
Hello.
lingula. Yeah, yeah, I'm here. Rakesh, can you hear me? Hey, Rakesh.
Yeah, there, I think there is some interruption. Now it's clear.
Now it's clear. Okay,
Yeah.
okay, okay, okay.
Mm.
Okay, so as I said, the upper lip of the calcaneus sulcus, which is formed by the cuneus, has been removed to expose the lingula that forms the lower bank of the calcaneus. So here we remove the upper lip of the calcaneus sulcus. This upper lip of the calcaneus sulcus is formed by the cuneus, and this has been removed to expose the lingula, which forms the lower bank of the calcaneus sulcus, as we can see here. So this is the calcaneus sulcus, and the lower part of this calcareous sulcus has been formed by the lingula. Okay, so the calcareous is a prominence in the lower part of the medial arterial wall overlying the calcareous sulcus. So the calcareous is a prominence in the lower part of the medial arterial wall overlying the calcareous sulcus. So yes, as it says, I cannot see here the calcareous, but it says that it's a prominence. Okay, uh, in the lower part of the medial arterial wall overlying the calcareous sulcus. Okay, so let's proceed to the figure M. Okay, so in figure M, the glomus of the choroid plexus has been reflected forward to expose the medial wall of the atrium. So the glomus of the choroid
Hello.
plexus has been, yeah, yeah. Hey
Yeah, yeah,
Rakesh,
I can.
is this interrupting?
Yeah, little. It's interrupting since last 2 minutes. Now it's
Aha,
clear. We'll
now it's
carry
clear.
on. We'll carry. Yeah.
Okay, okay, yeah, we will be shortly over with this part, so then we can go through some questions and we'll continue next time because this is really a giant
Yeah,
chapter,
yeah.
the first one. So we will do this in a few times.
Yes, yes.
Okay, so in figure M, the glomus of the choroid plexus has been reflected forward to expose the medial wall of the atrium. Okay.
Yeah.
The lingula that forms the lower bank of the calcareous sulcus has been preserved. So the lingula is here, and it forms the lower bank of the calcareous sulcus. So it has been preserved in this slide. Uh, okay, the calcareous overlies the deep end of the calcareous sulcus. So calcareous, as it was stated, calcareous is a prominence in the lower part of the medial atrial wall. So here, lateral to this is the atrium of the lateral ventricle. Medial to this atrium of the lateral ventricle is the calcareous. And this calcareous uh, forms the uh, overlies the deep end of the calcareous sulcus. So it goes deep beneath the calcareous. Okay, now we are proceeding to figure N. Here, Rakesh, are you here? Hey, Rakesh. Rakesh. Rakesh, man.
Yeah, hello, hi. I can hear you. There is a
Hey, you
little interruption.
little interruptions. Let me just see if we are. Yeah, we are online still. Okay. Well, I'll just try to wrap this up. We will finish this. I'll
Yeah.
just try to go quickly through what we have left, and then we are very close to the ends. Okay, so I hope this
Okay.
this works. Just indicate, please,
Okay.
if something happens. Okay,
Yeah,
thanks.
there is an interruption now.
There is an
Hello.
interruption now. Hello.
Yeah. Yeah. There was a small interruption again.
Okay, okay. So I hope this sticks
Mhm.
for a few more minutes. Okay. So figure N. The Volks has been removed to expose the medial part of the right hemisphere. The Volks has been removed to expose the medial part of the right hemisphere. Okay. The ascending ramus of the cingulate sulcus reaches the superior border of the hemisphere behind the paracentral lobule. Okay, so in O, figure O, which misses here, here Rakesh.
Yeah. Yeah.
Uh,
No.
uh,
Yeah. There is a problem there. There's a problem
yeah,
there.
can you please
Yeah.
share
Yeah.
the
Okay. Okay.
image? Okay, so we'll just go quickly through this
Yeah.
remaining part. We have O, Q, and that's it, and UV, TUV. That's we're very close.
Okay. Yeah. Can you see Slavan?
Yes, yes, I can see it. Great.
I think. Oh.
Okay. Oh, so uh, yes. Now in O, we have the pre and post central gyri have been removed while preserving the superior temporal gyrus. So the pre and post central gyri have been removed. The choroidal fissure, which is the cleft between the thalamus and fornix, extends from the foramen of Monro through the body, atrium, and temporal horn to the inferior choroidal point located just behind the head of the hippocampus. So the choroidal fissure, the cleft between the thalamus and fornix, extends from the foramen of Monro, okay, through the body, atrium, and temporal horn to the inferior choroidal point located just behind the head of the hippocampus. Okay, so we have this relationship here. In P, in figure P, we can see the superlateral view of the cross section of the central area of the hemisphere, which is positioned between the insula laterally and the ventricles medially. Okay, so again, we see the superlateral view of the cross section of the central area of the hemisphere, positioned between the insula laterally and the ventricles medially. The central core of the hemisphere, the area between the insula laterally and the ventricles in the midline, includes so the central core just a second. The central core of the hemisphere, the area between the insula laterally and the ventricles in the midline, includes the caudate and lentiform nucleus. Thalamus, uh, lentiform nucleus, thalamus, and anterior and posterior limbs of the genu of the internal capsule. Okay, so we have the central core of the hemisphere, which is the area between the insula laterally and the ventricles in the midline, which includes the caudate and lentiform nucleus, thalamus, and anterior and posterior limbs of the genu of the internal capsule. Okay, so then we will continue to the figure R. So
Q.
this
Q.
Q, okay, Q, sorry.
Mm. And
So it
Flavin,
just
I
says,
think after Q we have to go to questions. I think it's becoming a little bit more
yeah,
for the first session. Yeah,
yeah,
we'll
just
remember
I
it as
just
Q
wanted
for
to,
questions.
yeah, okay, let me just fast forward this a bit. I will just read from
Sure,
Q
sure,
to
sure.
the V. I just want to finish this. Okay, thanks.
Okay,
So
okay, we'll do. Yeah.
yeah, yeah. Okay, so the claustrum is positioned between the insular cortex and the lentiform nucleus. This was in figure Q. Okay, so now in figure P, but now we are going to the Q. Okay, so the superior temporal gyrus has been removed while preserving the long gyri of the insula. The ascending ramus of the cingulate sulcus marks the posterior edge of the paracentral lobule, the extension of the pre- and post-central gyri onto the medial surface of the hemisphere. Then on the letter R, we have the enlarged view of the choroidal fissure. The choroidal fissure extends from the foramen of Monro to the inferior choroidal point, located behind the head of the hippocampus. The choroid plexus, which attaches along the choroidal fissure, has been removed. The outer edge of the choroidal fissure is formed by the body of the fornix in the body of the ventricle, the crus of the fornix in the atrium, and the fimbria of the fornix in the temporal horn. Then, in letter S,
Can you repeat this R once again? I'll just show them.
yes, of course, of course. Okay, so
Yeah.
R, enlarged view of the choroidal fissure. The choroidal fissure extends from the foramen of Monro to the inferior choroidal point, located behind the head of the hippocampus. So the inferior choroidal point is located behind the head of the hippocampus. The choroidal plexus, which attaches along the choroidal fissure, has been removed. The outer edge of the choroidal fissure is formed by the body of the fornix in the body of the ventricle, the crus of the fornix in the atrium, and the fimbria of the fornix in the temporal horn.
Okay.
Okay, and now going to S. So a retractor has been placed between the thalamus and the crus of the fornix to open the choroidal fissure. Okay, opening the choroidal fissure in the body of the ventricle exposes the third ventricle. Okay, and we are very close now. Opening the choroidal fissure between the pulvinar of the thalamus and crus of the fornix exposes the quadrigeminal cistern, and opening the fissure between the lower surface of the thalamus and the fimbria of the fornix exposes the ambient cistern. So again, opening the choroidal fissure between the pulvinar and crus of the fornix exposes the quadrigeminal cistern, and opening the fissure between the lower surface of the thalamus and the fimbria of the fornix exposes the ambient cistern. So in letter T, the remaining insula has been removed to expose the thalamus, forming the inner rim of the choroidal fissure. The lateral geniculate body is exposed at the lower margin of the thalamus. The optic radiations pass laterally above the hippocampus in the roof of the temporal horn and posteriorly around the lateral margin at the atrium to reach the calcareous sulcus. Okay?
Okay.
Uh, Okay, just a second. To reach the Cochrane sulcus, the anterior wall of the temporal horn is formed by the amygdala, which tilts backwards above, but is separated from the hippocampal head by the temporal horn. Okay, and last
Okay.
two letters, guys. Okay, in letter U, we have the thalamus, which has been removed to expose the third ventricle. So the thalamus has been removed in order to expose the third ventricle. The body, crus, and fimbria of the fornix, forming the outer margin of the choroidal fissure, have been preserved. Opening the choroidal fissure in front of the crus of the fornix exposes the pineal region and quadrigeminal system around this pineal region. Okay, so just a second. I'm sorry. I think it goes like this. Opening the choroidal fissure in the temporal horn exposes the ambient cistern and posterior cerebral arteries. Okay. The medial posterior choroidal arteries are exposed in the quadrigeminal cistern. Okay. The stria medullaris thalami marks the lower edge of the velum interpositum, in which the internal cerebral veins course. So the stria medullaris thalami marks the lower edge of the velum interpositum, in which the internal cerebral veins course. And the last letter, V, the left half of the body of the fornix has been folded downward to expose the right half of the body and medial aspect of the contralateral choroidal fissure located between the body of the fornix and the upper surface of the thalamus. The pineal gland and posterior commissure are exposed at the posterior margin, and the anterior commissure and columns of the fornix are exposed in the anterior margin of the third ventricle. Okay, so I think this is more than enough for the first part. We will
Mm.
certainly get better in this, guys, because this is just the really the first session. And now I would like to give this microphone to Rakesh here, who will now
Yeah.
ask some questions. So Rakesh, if I haven't exhausted you, please take over.
Yeah. It was very nice reading through. It was crystal clear. As Slavan said, this is our first Rhoton hangout, so we'll get better. We'll get better from, and it was a very spontaneous one. In fact, it is 2
Mhm.
a.m. from where I am speaking. 2 a.m. from where I am
2
speaking. This is
a.m.
yeah. So this is our interest and love towards neuroanatomy. So we have just started it spontaneously. We'll get better. We'll just go with some of the questions. I'll just screen share, Slavan.
Of course. Yeah. Rakesh, you're a hero, you know. Like
Yeah. Oh my
2
God, you're
a.m. and
making me hero. I'm not.
thinking so bright, man.
Yeah, no,
Thinking so
you're
bright in
making.
2 a.m. Great. Yeah, so
Okay,
we'll see this, man. Yeah, that's
yeah,
a neurosurgeon speaking there.
yeah. So all our viewers, just this is just a spontaneous one. We are taking some neuroanatomy questions from Comprehensive Neurosurgery Board preparation book. As again Slavan mentioned, we are using the legal version of these books, which has been bought as an online version. So, right, Slavan?
Yes, of course. Sorry, I
Yeah.
muted just to not to make disturbance in your sound.
Okay.
Okay.
Okay. We'll just go to the anatomy part. Yeah. Here we come with the anatomy.
Okay.
Yeah. As we are saying, this is a spontaneous one, and if we'll go through the questions, and if it was in an area that we discussed just now, so then we'll analyze it. So going through the first question in a neuroanatomy,
Hmm.
lesion in the pulvinar nucleus of the thalamus can result in A. Neglect syndromes, B. Anosmia, contralateral sensory loss, endocrine dysfunction and abnormalities, memory difficulties. The question reads as a lesion in the pulvinar nucleus of the thalamus. A thalamus has various nuclei. In fact, I think separated by the laminar.
Hmm.
and they are asking here if there is a lesion in the pulvinar nucleus of the thalamus, what does it result in? So any
Yes.
ideas, Slavan?
Well,
Is it a Neglect
let me
syndrome?
just
Is it
orient
anosmia?
myself.
Okay, okay, you can
Well,
just analyze
we
it.
have yeah. So we have pulvinar. I just wanted to ask you. You have answers to these questions on in the back
Yeah.
parts of the book. Yeah.
Yes,
So
yes.
I
I'll.
think we should
Yeah. Okay.
best
Okay. We'll.
discuss and then read the answer after we get some speculations. Okay.
Okay. Can you
So
take
let
this
me
one?
see. Sorry. Sorry.
Can you do you want to analyze this one or the question?
Y- Yes, I would like to try to guess, and please, guys, don't make too much fun of me if I get it completely wrong.
Son of us, in
But
fact, son of us.
yeah,
Yeah.
so I'm trying to pulvinar nucleus of the tongue. So we have neglect syndromes, anosmia, contralateral sensory loss, endocrine dysfunction, memory difficulties. Well,
It's,
this is this
it's
hard one.
yeah, hard one. I think Slaven will go to the answer. We'll just discuss it.
Yeah, okay, let's go to the
Yeah, it's a
answer.
difficult.
I have no idea. Yeah,
Okay.
just to be honest, that's the best thing.
Yeah, yeah.
But we have these great books, and make sure, guys, to prepare yourself right and buy these books. We're
Yeah,
promoting
yeah,
here.
yeah, yeah, yeah. We're promoting. Yeah, we're promoting this. I just go to this thing.
Yeah, we have no interested, material interested in this because we're
Yeah,
just doing this for the sake of honor of neurosurgery and
yes.
ourselves.
Yeah, I think it's 168. We have interest. I and Slaven have interest, and the interest is only about increasing our knowledge and no other
Of
interest.
course,
So, yeah,
of course, of course. Yeah, yeah.
yeah,
As you said, that's more correct. Yeah.
yeah. 168. Slaven, 1 minute. Slaven. I have to go to
Yeah,
168 now.
just take your time. Take your time. We relax here.
Yeah, I think yeah we have. Yeah, I have come to anatomy. I'll go to the first question.
Hmm.
So yeah.
I think
Okay, here
Rakesh.
we yeah this they say the neglect syndromes, and now I want to say that my back of the mind I was thinking about neglect syndrome. Okay.
Hmm.
Hello.
Great, great, great.
Yeah. Yeah.
Yes, yes,
So
yes.
the so nucleus of the thalamus
Rakesh.
and the yeah tell me.
Yeah, yeah.
Hello.
It's okay. It's okay. It's okay. Continue, please.
Uh, okay, pulvinar nucleus lesion results in neglect syndromes. Neglect syndromes and additional deficits can occur with pulvinar nuclear lesions. The pulvinar nucleus is the largest nucleus of the thalamus. It is located most posteriorly and is associated with visual pathways. They just have told about the option E, that is memory difficulties may occur with lesion of the anterior nucleus of the thalamus, which is considered as a part of limbic system. So basically, this question analyzes about the anterior nucleus and the posterior nucleus. The most largest nucleus in the thalamus is pulvinar, which is posterior. So you can remember as P for P, that is pulvinar is in the posterior and it is the biggest one. And this is associated with the visual pathways. And the lesion here causes neglect syndromes and attentional deficits. The add-on information here is there is an anterior nucleus in the thalamus which is concerned with the limbic system, and a lesion over there can result in memory difficulties.
Amazing, amazing, Rakesh.
Okay.
This was
Uh,
great for
yeah.
P. Thank you.
Yeah.
Okay, so
Okay.
let's go
Okay.
through a couple more,
Couple more. Yeah.
if you agree.
I think for the start it is it's a good start for us. I believe so.
Yeah, yeah, yes.
Yeah.
This
Yeah.
is
Yeah.
amazing. I
Yeah.
really
Yeah.
enjoy
Yeah.
your
Yeah.
discussion.
Yeah.
Mhm.
Yeah. Yeah. Yeah, here we go. Second one is a case scenario. It seems like it says a 67-year-old woman presents with a follow-up presents for follow-up 4 months after a stroke. She complains of her eyelids twitching. She is found to have palatal myoclonus on physical examination. Her stroke likely involved which region of the brain? So here the question is on a 67-year-old woman who has come for a follow-up 4 months after her stroke, and she complains of her eyelids twitching, and on examination you have palatal myoclonus. And the question is, which region of the brain has was involved in a stroke? The options are nucleus ambiguous, tectospinal tract, rubros olivary tract, or the central tegmental tract, triangle of Mollaret, body of the caudate nucleus, and the lateral lemniscus. For me, it's again a difficult one. What do you say, Slavan?
Yes, yes. Again, difficult. I'm examining the proposed answers, but I think, well, I would go with, let me just guess that it's E, lateral meniscus. But
Lateral
I'm
yeah,
really
yeah,
not sure what I'm
just
talking here.
yeah, it's just a guess. It's better than being silent. Just a guess. Yeah, I think I'll go to the answers and just discuss. And I hope Slavan is right.
Yeah, I agree. Well, if I'm not, at least I'll learn. I think what's great,
Yeah,
these questions are
yeah,
really like pearls. This is
yeah,
really, they're
yeah,
hard, and this is great.
yeah, yeah.
Oh,
So the answer says it is C, rubro-olivary tract, central trigeminal tract.
yeah.
So to just crack a joke here, there was one friend of mine. There was one friend of mine who had a very weird trick for such
Uh-huh.
multiple choice questions. He used to tell me, we used to discuss, and he used to tell me that whenever you find a very difficult question, you don't know anything about it, just put a option which has the longest most words in it, which is the
Oh,
longest
yeah.
option. So, yeah, I used to say this. Now I feel it is right. Most of the times I've seen it's right. Yeah. So
Yeah, amazing. Yeah, Rubro.
yeah,
Exactly, man.
yeah.
Like, yeah.
Yeah, he used to tell this very seriously. I used to joke him, but he was very serious in his option.
Yes, you should
Okay.
try to bring your
Yeah,
friend
yeah,
to hang out, and we'll try to
yeah,
work with him. Yeah,
yeah,
on
yeah.
these questions.
Okay. Let's continue. So the question was to revise a 67-year-old woman 4 months after the stroke, coming with complaints of twitching in her eyelids as on symptom, and an examination. You see a palatal myoclonus, and the region was told to guess to answer, and the region is rubro-olivary tract, the triangle of Mollaret. The function of the triangle of Mollaret is a functional circuit connecting the dentate nucleus of the cerebellum to the contralateral red nucleus through the superior cerebellar peduncle, the red nucleus to the ipsilateral inferior olivary nucleus through the central tegmental tract, and the inferior olivary nucleus to the contralateral cerebral cortex. I think this we we have to discuss when we go to cerebellum. Slaven,
Yes,
what do you
yes,
say? Because this is
yes.
going above my head. This is going above.
Absolutely agree. Yeah,
Yeah, yeah.
we can just go through it for now, and then we'll think about it later, like
Okay,
like
sure.
Chinese people have a
Yeah,
saying,
yeah. That's true.
postpone
That's
it for
true.
tomorrow.
Yeah, yeah. Retrograde. Okay. The triangle of Mollaret is a functional circuit connecting the dentate nucleus of the cerebellum to the contralateral red nucleus through the superior cerebellar peduncle, the red nucleus to the ipsilateral inferior olivary nucleus through the central tegmental tract, the inferior olivary nucleus to the contralateral cerebellar cortex through the inferior cerebellar peduncle, and the cerebellar cortex to the ipsilateral dentate nucleus. A lot of connections here. Lesions
Yeah, they
of
really
the
couldn't make it make it. Okay.
lesions lesions of the triangle of Mollaret produce palatal myoclonus. This is what I take from this question. The lesion in the triangle of Mollaret produces palatal myoclonus, which
Mhm.
is one of the few movement disorders that do not disappear during sleep. Yeah, to the viewers, this is one of the question I read in some of the MCQs. What doesn't
Mhm.
disappear during sleep? Palatal
Mhm.
myoclonus is one of the two. The other one I don't remember. Palatal
Mhm.
myoclonus you can see even during the sleep of the patient. So palatal myoclonus appears in a delayed fashion following such lesions. Ocular myoclonus can accompany palatal myoclonus due to the lesions in the central tegmental tract. This is what happened to this patient.
Mhm.
So, so what I take from this explanation is one of the thing what I revised is palatal myoclonus is one of the movement disorder that doesn't disappear in sleep, and
Mhm.
the lesion in the triangle of Mollaret causes this disorder, that is the palatal myoclonus. And these connections, as of now, is a little bit confusing without the neuroanatomy. Once Slaven makes a neuroanatomy clear of this part, we can go through this question once again.
Yes, yes. So
Okay.
we'll remember this. This is the question number two in anatomy. Okay, maybe
In
there will
anatomy.
be the day that we. Oh, this is simple. Like this is the most
Yeah,
basic
yeah,
thing we
that's right.
know.
Yeah, yeah.
Okay.
Should we go for the third one?
Yeah, let's go for a couple more. As
Okay,
far
sure.
as you have, as you can keep yourself awake. Okay, since it's
Yeah,
two
yeah,
two
sure, sure.
a.m. there. I mean,
I think
okay.
yeah, yeah. I think we'll do this one, third one, and we'll
Okay.
wrap up for today, and then we'll start. Okay. The third question is, it says the ventral tegmental area sends projections through neuroanatomic structure to the nucleus albicans accumbens as part of the
Mhm.
dopaminergic mesolimbic system involved in uh, a, a reward
Reward security.
circuitry. Yeah.
Mhm.
The options are medial forebrain bundle, lateral hypothalamus, ventral pallidum, and the prefrontal cortex.
Okay, let me try to hit on this one if you agree. I would say medial forebrain bundle. Okay.
Okay, let's go to the answer now.
Yeah, let's go to the answer, please.
This is fun. Yeah, we'll improve a lot for the
Yeah.
second time. Yeah, we'll bring in the questions
Yes,
which
yes.
are relevant to the discussion, so that it will be
Uh-huh.
more the thing. So we'll collect the questions about the part we are discussing, so that we will be okay.
Yes,
So
yes.
it says middle forward bundle. Yeah, there will be a big treat in Croatia.
Oh yeah, well, yeah, yeah. So we will celebrate for sure.
So Slavan was right. The medial forebrain bundle carries information from the ventral tegmental area to the nucleus accumbens in the ventral stratum. The nucleus accumbens also receives input from the hippocampus, amygdala, prefrontal cortex with output to the ventral pallidum. So
All
they
right,
say
all right.
medial forebrain bundle carries information from the ventral tegmental area to the nucleus accumbens in the ventral stratum. Okay, the nucleus accumbens also receives input from hippocampus, amygdala, prefrontal cortex, and the output to the ventral pedum. Basically, I think it's concerned with memory. Whatever comes with hippocampus, amygdala, it's concerned with memory.
Yes,
Yeah.
yes,
Okay.
exactly. And
Okay.
pleasant memories of reward, as it's
Of
stated.
reward.
Because if you stick, this has to do with how can you say when you're used to things and you are also dependent with dependency on
Okay.
drugs perhaps.
Okay. Yeah.
So
Yeah. 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 Right. Right.
yeah, because it's the water
Right.
center, so when you stick a wire there in the
Addiction.
monkey's head.
You're telling addiction. You're telling about like cocaine and all.
Yeah,
Are you?
addiction,
Yeah.
addiction.
Yeah. Yeah.
Exactly, yeah,
Right.
exactly, yeah.
Yeah.
So when you put an electrode in this ventral tegmental area in the monkey, and you give
Okay.
him the ability to press this electrode to activate it, it will do
Okay.
it as long as he dies. You know, he won't
Hmm.
even have the last to eat. So I
Okay.
remember this from a medical school. So I would like to commend here the University of Zagreb Medical School and
Yeah.
and its neuroscience lectures who really taught us this. So
That's great.
amazing
That's
people
great.
there.
Yeah,
Thanks.
that
Okay,
says
so let's can we just go through the 4 and 5? I'm really interested now. Just to
sure,
wrap it
sure.
up.
Oh, that's nice. That's yeah, sure, sure.
Yeah,
We'll
please,
continue for
Rakesh,
five
please,
questions.
Rakesh. I'm enjoying
Slaven,
this.
as you see, Slaven, as you see, is a very hardcore neuro. He loves neuroanatomy. He loves neuroanatomy.
Oh yeah, but I really do, man. And they made me, they learned me how to, taught me how to
Yeah,
love it. I appreciate
yeah,
that,
yeah,
and Professor Rhoton
yeah,
especially. Thanks. Thanks.
yeah, yeah. So, continuing this, use the following answers for questions 4 and 5. So, they have given a few options, and we have to match it for the fourth and fifth question. I'll read out the options. That is area prostrema, nucleus tractus solitaris, the NTS, and nucleus prepositus hypoglossi. So, it is the 12th cranial nuclei. Nucleus ambiguous. I think this is related to 9, 10, 11 cranial nerves,
Mhm.
and the
Yes.
inferior salivatory nucleus. So these are the options. So the question number four is, what structure is the target for taste afferent fibers? I think this you can tell. I think I can tell this. What do you feel, Slaman? What's your option?
Yes, well,
Taste, taste.
you should. Yes, yes, taste.
Yeah, this one I think if it is taste, I think it's between nucleus tractus solitaris and inferior salivary nucleus. I think I'll go for nucleus tractus solitaris. I feel I remember that the taste. What do you feel?
Well, taste. That's just a second. Well, I agree with you. Yeah, I
Okay.
would also choose nucleus tractus
Uh,
solitarius.
okay.
Okay.
And the fifth question asks, what structure is the autonomic center of vomiting? Yeah, this also I think I know. Area postrema.
Right.
This is the area postrema. Yeah.
Yeah, really,
Okay.
I agree.
Area.
Completely agree.
You also agree with area postrema. Okay. Let's see the. Let's
Yes,
go to the
yes,
answer.
yes, of
Yeah.
course.
Yeah. Yeah. Okay, going to the, yeah, we both are right. Croatia, we are improving. We are improving.
All
Out
right,
of the five,
man.
yeah. Last three
Yeah.
questions we are bang on target. Last three questions we are bang on target.
Great, man. Great.
Yeah. Okay. Let's go through the answer. It says nucleus tractus solitaris is a medullary nucleus, also receiving afferents from chemoreceptors in the aortic and carotid bodies. Okay.
Okay.
The question was the taste. So nucleus tractus solitaris is associated with taste, and also they say they're associated with chemoreceptors in the aortic and carotid bodies. So these bodies are
All right.
to the viewers linked to the small chemical, the important chemical changes in the blood, that
Mhm.
is of oxygen and carbon dioxide. They say that they're the most sensitive structures in the body for small amount of changes in carbon dioxide. They are the chemical mediators that send the signals to the brain whenever there is increased concentration of carbon dioxide in the body. So any
Amazing.
comments, Slaven? You,
No,
I think,
no. I
yeah.
think you explained it all. I wouldn't. A great explanation. Okay.
Okay, okay. So basically, they are associated with the taste and the oxygen carbon dioxide balance in the blood through aortic and carotid bodies, mainly present in the bifurcation of the carotid artery into
Yes.
external and internal.
Exactly.
Okay, coming to the fifth, what the question was vomiting center. It's called vomiting center, area postrema. Area postrema is located in the medulla and is the only paired circumventricular organ. So there are some circumventricular organs. I think these organs are the organs where there is no blood-brain barrier. If I'm sure, what do you say, Slaven?
Yes. Yes. Yes.
Yeah.
Yes.
So
Exactly. These are where it
yeah.
comes in direct contact with the blood. Yeah.
Okay, there is some mnemonic SOAP, SOAP, where P is postrema. I remember this. I think we can go in detail when we come to this part. As of now, area postrema is the only paired circumventricular organ. The nucleus, they have told about the nucleus preposite hypoglossi is medullary structure and neural integrator responsible for horizontal gaze control during smooth pursuit eye movements. So they have explained about one more option they had given for this thing, that is hypoglossa is associated with horizontal. I always have this habit of keeping a mnemonic like H for H, P for P. As I told, P for P in posterior pulvinar hypothalamic nuclei. Sorry, thalamic nuclei. Now here I go for H for H, that is hypoglossi is associated with horizontal gaze. Hypoglossi, the
Great.
nucleus.
Great. Great.
Yeah, preposite hypoglossa is
Amazing
associated
mnemonic.
with horizontal.
Yes.
Yeah, horizontal. And the D, that is nucleus ambiguous, is located in the lateral and rostral medulla and supplies efferent motor fibers for the hypoglossal and vagus nucleus. Oh, as I said, this nucleus ambiguous is associated with three cranial nuclei. I've seen two here, that is 9 and 10. So I had read
Mhm.
that it's associated with 9, 10, and 11. Okay. So,
Great.
and inferior salivary nucleus is a medullary structure responsible for parasympathetic efferents to the parotid gland to induce salivation, as it says the salivatory nucleus salivaceous salivation. So inferior salivatory nucleus is produces saliva from parotid gland. So that's all about these options. They have explained each of the options along with area postrema and nucleus tractus solitaris.
Great.
Okay,
Okay.
Lavins.
Okay, so
So this is addiction. This is addiction for us. Like,
yeah, exactly, exactly.
yeah,
The ventral
uh,
tegmental area and
yeah,
the forebrain
yeah.
body.
Uh, okay. I hope
Yeah,
it becomes a
I'm
great
feeling
addiction
the
for us.
stimulation
And
here.
yeah,
Hmm.
yeah, guys. So you're all welcome. This as Slavan and I have just started it very spontaneously at 2 a.m. here where I am, and I think it's almost 11 p.m. or 12 p.m. when 12 a.m. where Slavan is.
Exactly,
So
exactly. Yeah, almost
yeah,
11.
yeah. So we are just so interested that we had a plan to start since long time, and we have just started today spontaneously. I think the questions didn't match with the discussion, so we'll plan and match the questions with the discussion we had during the next seminars. So you're all welcome to join it. Okay, thanks, Slaven. Thanks, Slaven, for me being a motivation to start this. And as you
Oh,
all know, Slaven has a Rhoton course, so he is authority. So you will be confident in your neuroanatomy through these discussions. Slaven, you have
yes,
anything to
Rakesh.
say?
Well, first, can you? You're getting off the screen. Yeah, I want to see you,
Yeah,
man. That's it.
yeah. Okay,
I'm just
okay.
joking,
One minute.
joking. Yeah.
1 minute. Yeah, yeah. 1 minute. I'll come there. I'll come there.
Okay. So here is
Yes.
the brilliant
Yeah.
Rakesh, who
Yeah.
you just had the opportunity to listen. I'm really admiring Rakesh, how you really have knowledge, and I what I
Yeah.
admire, you have this uh, organized knowledge, and that's great
Yeah.
about you because I
Yeah.
tend to think I think like a caveman. I think clock all around, like in a radiant manner, but you have this you really know things organized. So I think we can both benefit from this, and I
Yeah. Yes.
really
Yes.
think this is the start of something great. So I really appreciate you giving the half part of
Yeah.
this and really
Yeah.
helping me out because
Yes. Yes. Yes.
I don't like to do things only myself. I really
Yeah. Yeah.
but because it misses the diversity, and it also misses another human spirit. So this is
Yeah.
really a conjoined effort between you and me, and
Yeah. We
I'm
have to
really
do.
what we can achieve. I'm glad that we started this.
Yeah, this is nice. It's like one goes through the theory, and in fact, I think, Slavan, the pictures. If we go to through the theory, like we just did in the beginning, it little monotonous. But anytime reading
Hmm.
Rhoton is an addiction. But the way you were discussing the pictures, it was lively. So we'll discuss the pictures because anatomy is all about pictures, and
Yeah,
neuroanatomy is
exactly,
the same. So and then we
exactly.
go to questions. One guy will do this thing explanation through the theory, and one guy will go for a question. So that will be awesome, and we'll have fun like this,
Hmm.
and we'll have more people joining in,
Amazing,
and yeah,
amazing.
Rotan
Yeah.
will become
And
yeah,
yes, and we
and then
hope really people to join. And so if all our viewers can really feel free to participate, the link will be available, and you can just visit on my YouTube channel for now. But I'm sure Rakesh will host some of these in the future
yeah,
as well. So
sure, yeah,
you can contact either him or me, and yeah, let's make.
yeah. And as of now we have if you want to have any questions, queries, or any suggestions, we have something called a neurosurgeryconnect@gmail.com. Yeah, all you can just give us messages, or we have, in fact, we are members of neurosurgical.tv, wherein we have a great neurosurgeons across the world coming and giving their seminars over this. So if you have any suggestions, you can put over there. So this is basically a Rhoton course going international. We just started today for the first one with the Slaven. Slaven actually has a Rhoton course going on in his country, that is Croatia, in Zagreb, the
Mhm.
capital, and we are going
Yes.
to make it international. This is the first online thing. It was spontaneous. We'll get better, and we want you all people to just come in and make this better and better. Thank you.
Yes, I want you all to be hardcore and at 2 a.m.
Yeah, yeah,
Dig
yeah,
through
yeah.
Rotten, and I think this is perhaps the best bad night story that you ever had, Rakesh.
Yeah, yeah. I'll remember it forever. So
Great, great.
cool, cool.
Okay, so
Close it. Close it.
as Rakesh said, I really thank to all our viewers, and really I hope we will stick along in the future. And so we're going through our next hangout will be soon, and we will continue to discuss the cerebrum and another set of neuroanatomy questions by handsome Dr. Rakesh here. Okay, so
Okay. See you. See you
okay,
soon.
so Rakesh, thank you so much for
Yeah.
coming, and thank you
Sure.
all who
Thank
viewed
you.
this.
Thank you.
Okay,
Thank you. Thank you.
bye guys.